Hello Helites, welcome so much. I am your Helite pharmacist today. So we are beginning our channel with a very interesting topic, the pharmacology of peptic ulcer disease. So guys, what is peptic ulcer disease? So peptic ulcer disease is defined as erosions in the stomach lining of greater than 0.5 centimeters. Like any other disease that you'll encounter in life, what happens in disease state is that there's actually an imbalance between the factors that are aggressive towards the disease condition and the factors that are defensive. So in peptic ulcer disease, there are some of the defensive factors that will cause a neutralization in the stomach. The defensive factors will include something like the mucus, hydrogen, the bicarbonate, high blood flow, and also the number of prostaglandins that are present that are being produced in the body, and specifically that are being received by the prostaglandin receptor that is in the parietal cell. So I want us to discuss the physiology, the normal production of acid state, all the normal production of the acid in the stomach lining. So what happens is that there are three main receptors that are involved in the production of the acid, which include the muscarinic receptor, the cholecystokinin receptor, and the H2 receptors. So when there is stimulation, for example, of the H2 receptor in the parietal cell by histamine, it causes a stimulation to the proton pump, which actually pumps an hydrogen proton in exchange of a potassium proton. So the same happens with gastrin, and the same happens with the muscarinic receptor. So gastrin and muscarinic receptors, what they do is that they produce a calcium ion, and the calcium ion is the one that stimulates the proton pump, while histamine produces CAMP, which is cyclic adenosine monophosphate, which now stimulates the proton pump, and the proton pump now pumps an hydrogen ion in an exchange with a potassium ion. So unlike histamine and the rest, now the prostaglandin will also work in the same way, but prostaglandin actually inhibits the production of the cyclic adenosine monophosphate. Therefore, when there is excess of, for example, prostaglandin E, what happens is that there's reduced production of hydrogen ions, because we have inhibited the cyclic adenosine monophosphate. Now prostaglandin E also is also received by a prostaglandin receptor in another cell in the stomach lining, which is a part of the epithelial cells. So this cell, what happens to prostaglandin is that it has two mechanisms of actions. So one of the mechanisms of action is inhibiting the production of hydrogen ions. The other mechanism of action is that it actually stimulates the production of hydrogen carbonate ions and also the production of mucus. So that is why we included prostaglandins as part of the defensive components in the peptic ulcer disease. So what are some of the factors that will cause all these imbalances, hence leading to peptic ulcer disease? The commonest of the factors will include NSAID. So chronic use of NSAIDs leads to an inhibition in a process of prostaglandin synthesis. So there's an enzyme that is in the pathway of prostaglandin synthesis that is called cyclooxygenase. So what cyclooxygenase enzyme does is that it ultimately leads to production of prostaglandins from lipids. So when you inhibit this step, you will actually inhibit prostaglandin synthesis, and as we say that prostaglandins is one of those components that are crucial in the inhibition in hydrogen ions. So when the prostaglandins are not available, there will actually be an excess of hydrogen ion synthesis, and this one will lead to hyperacidity. Also, note that prostaglandins are also involved in the production of the bicarbonate ions. So this will actually lead to low levels of hydrogen, to low levels of the bicarbonate ions, and that will increase the acidity, which will ultimately lead to hyperacidity. The other condition which is highly linked to the stomach ulcers or the peptic ulcer disease is the H. pylori. So H. pylori in full is Helicobacter pylori, which is a gram-negative bacteria. So it is it's actually the commonest cause of the peptic ulcers in the current situation, because what happens in Helicobacter pylori is that it has an enzyme that is called urease. So urease is able to convert urea to ammonia. So when there's actually production of ammonia, there is ammonium, which is alkaline in nature, enables these bacteria to survive in the acidic condition. So the acidity of the stomach does not destroy this Helicobacter pylori. Now when the bacteria is able to survive in the stomach lining, it goes ahead and destroys the stomach tissue, and this leads to building up of ulcers. So presence of Helicobacter pylori does not necessarily mean there's actually hyperacidity, but it will lead to presence of ulcers. Now these ulcers can be affected by the usual acid that is in the stomach, and it will cause the ulcers to even increase. The other factor that is highly linked to the peptic ulcer disease is pathogenic hyperacidity. So these are conditions that will just increase the production of acid in the stomach, and when there is excess acid, which can be caused by, for example, when there is excess production of histamine, it will ultimately lead to excess production of hydrogen ions, and the same happens for gastrin and also for the acetylcholine. So those conditions that are able to increase the production of this pathogenically will also cause us to ultimately go to peptic ulcer disease. So we are going to look at the drugs now that are used in the treatment of PUD, and there's a mnemonic that is here that is so easy for you to remember in your drugs. So we are going to use this mnemonic to know the number of drugs. But even before we go there, one of the things that are very sure is that these drugs are actually going to be targeting all this. So for example, when we have this histamine receptor, and the histamine receptors are of course being stimulated by histamine. So a drug that is going to be effective here is actually going to be histamine antagonist. So this one will help you so easily to remember the mechanism of action. So what histamine antagonist does is that it competitively inhibits the histamine receptor. So the histamine that was supposed to bind here and now stimulate the whole pathway, an histamine antagonist comes and binds and does not stimulate the pathway, and therefore ultimately there will be no production of hydrogen ions. So the second in the category is an antacids. So before we go to the antacids, examples of histamine receptor will include drugs like cimetidine, ranitidine, and famotidine. The second category is the antacids. So antacids can be broadly classified into systemic and locally acting antacids. So what antacids do is that they are used to relieve the acid condition in the stomach just just for a short while. Now what they do is basically they are weak bases. So from simple chemistry, a weak base plus an acid will actually lead to neutralization of the acid by production of a salt. So remember that they will act here, and this is the lumen of the stomach. So when they neutralize the acid, they have not inhibited the whole process of production of the acid. So the production of the acid will continue, it will continue, but we will just be neutralizing. So these ones cannot be used to cure the situation or to treat the situation. What they will do is that they will only be used to relieve acutely hyperacidity. So the systemic antacids will include sodium bicarbonate, and then the local antacids will include aluminium hydroxide and magnesium hydroxide. Now aluminium hydroxide and magnesium hydroxide are the most commonly used because they have high efficacy and also they have very low adverse effects. So the antacids are basically systemic and also they can be local. So an example of systemic is sodium hydrogen carbonate, and the local ones include magnesium hydroxide and aluminium hydroxide and calcium carbonate. Now sodium bicarbonate is not a very popular one because it leads to some very serious side effects. For example, it leads to systemic alkalosis. It can also lead to belching, and also because of the high number of sodium, it can lead to sodium overload in the body. Now calcium carbonate also is not commonly used because it is highly linked with hypercalcemia, which is actually high amount of calcium in the body. So magnesium hydroxide and aluminium hydroxide are the most commonly used, and it is a very suitable combination because they tend to cause some adverse effects that are actually an opposite of the other. So aluminium hydroxide highly causes constipation, while magnesium hydroxide highly causes diarrhea. So when they are used together, they are able to cancel the effect of each other, hence stabilizing the patient. Now the third one here is mucoprotective agents. So these ones what they will do is that they create a layer. For example, assuming that this is our ulcer, a mucoprotective agent will come and coat it. So example of a mucoprotective agent is the sucralfate, which is actually a salt of sucrose that has been conjugated with aluminium hydroxide. So the third category, the fourth category, is the antibiotics. So the antibiotics are only used to treat conditions where the causative agent is the H. pylori. And so what they are used to do is that they are used to eliminate H. pylori. So these are basically antibiotics, and in the treatment of H. pylori, a combination therapy is highly used, unlike in other conditions. So when you target H. pylori, what is used is basically a combination of a proton pump inhibitor plus clarithromycin and then amoxicillin. Now in cases where amoxicillin, the patient has an allergy to penicillin, an agent that can be used in place of amoxicillin is metronidazole. So one thing with this regimen is that a single regimen should not be used to prevent the resistant to the Helicobacter pylori bacteria, and also these agents should actually not be replaced. So for example, if you are to use you are guided in using amoxicillin, unless otherwise the amoxicillin should remain in the regimen. So we go to the next category, the category number 5, which is antimuscarinics. So antimuscarinics include drugs like olanzapine. So just like the histamine antagonist, what the antimuscarinics do is that they competitively inhibit the M3 receptors. So when they have inhibited that process, they will inhibit the binding of acetylcholine, and ultimately there will be no production of hydrogen ions. So the next is prostaglandin analogs. So when you increase the level of prostaglandin analogs, you've actually inhibited the production of CMP. So when there is inhibition in the pathway of stimulating the proton pump, there will be ultimately a decrease in the number of hydrogen ions that are being produced, and ultimately you lower the acidity. So the very last one is actually the proton pump inhibitors. So this pump here is the last process in the production of acid in the stomach parietal cell. So when this process is inhibited, it means that regardless of the other steps that have occurred previously, there will be no production of acidity. Now, drugs that are examples of this include omeprazole, rabeprazole, pantoprazole, among others. There's one unique thing with these drugs in that they are all produced, they are all manufactured as prodrugs, and the prodrug is only activated in an acidic environment. So what happens is that the oral drugs are enterically coated to prevent them from premature denaturation in the stomach cavity. So when the drug reaches the alkaline environment in the duodenum, the enteric coat is removed, and the drug is absorbed still as a prodrug, and it is taken by the blood to the parietal cell of the stomach lining. So in the parietal cell, what happens is that the drug is, because of the acidic condition that is necessary to activate it, the drug is actually activated to an active metabolite. So what will happen here, for example, if you have this as the prodrug in the acidic environment, now the drug is made active, and the active drug now forms a disulfide bond with this enzyme, which is a covalent bond. Now when that covalent bond is formed, this enzyme is actually inhibited. The enzyme is actually inhibited. So when the enzyme is inhibited, the process is an irreversible process. So the only way now you can be able to pump other hydrogen ions to the stomach lumen is when there's a synthesis of another proton pump, a process that will take about 18 hours. So this will make it so interesting for these drugs, because although they have a plasma half-life of about 3 hours, they still have a duration of action of about 18 to 24 hours, because it will take 18 to 24 hours for other proton pump inhibitors to be synthesized. So that was it, guys, about our drugs. Let's get to the side effects and the adverse effects of the drugs.